live? All right.
Okay, good.
Take two, Dr. Ballios.
Let's do it
You
again.
ready?
Let's try it again.
Let's try this again. So for those of you who joined us for take one, I hope that you enjoyed watching us sideways or upside down.
Upside down. On our
Sideways.
heads.
Hope we looked especially fetching in
Amazing.
sideways mode. So hopefully this is the correct orientation. So I hope that you're still tuned in. Maybe more people have joined us. Excellent. Let's start fresh, though,
Okay.
for those of you who
From
might
the
be
top.
new. You can hear us all again in the correct orientation. So my name is Dr. Mary Sunderland, and I'm the Director of Research and Education here at the Foundation Fighting Blindness in Canada. And today is a very special Facebook Live session because, obviously, I have Dr. Brian Ballios here with me in the Foundation Fighting Blindness office. So rather than me introduce you, Dr. Ballios, would you like to introduce yourself to all of our friends here?
Sure. Well, thanks, Mary. I'm really pleased to be joining everyone here today. I'm a senior research associate and a resident physician in ophthalmology at the University of Toronto. And from the research side of things, my interest for many, many years has been on developing new stem cell therapies for the treatment of blinding eye disease. My research is specifically focused on replacement of the photoreceptor cells in the retina, but also using some of my engineering background on bioengineered approaches to enhancing the delivery of those cells. And then the clinical side of my work, of course, I'm passionate about clinical care and ophthalmology, but I also get to engage, every day with patients who are suffering from these blinding eye conditions, and it's very motivating and very interesting to hear their stories and find out just what they're looking for from new therapies that we're hoping to develop.
Well, and what Dr. Ballios didn't mention, one of the other reasons why we're thrilled to have him here today is because he is the inaugural recipient of the, this is a long title, Foundation Fighting Blindness Clinician Scientist Emerging Leader Award. So this is a new award we've just launched this year to support people who are doing the very important work like Dr. Ballios, where he's in the clinic, he's actively seeing patients who are living with blinding eye diseases, and he's in the laboratory working with stem cells in a dish, in animal models, trying to figure out how he can take these cells forward to a place where they will be ready to deliver as treatments to those patients that he sees every day. So this is a critical area of expertise that we need to make sure we have in Canada if we want to be ready to have arms of these emerging clinical trials where new ones really seem to be starting every day. And the other thing Dr. Ballios didn't mention, he mentioned during his introduction that he has this kind of unique bioengineering approach to stem cell transplantation. And this was a great week because Dr. Ballios' PhD supervisor, Dr. Molly Shoykett, actually won a very prestigious award, the Killam Prize. So maybe,
Yes.
Dr. Ballios, do you want to say a little bit about that?
Yes, well, my background drew me to work with Molly Shoykett in bioengineering because as an engineer I was always interested in applying the scientific principles to different problems in the real world. And what really drew me to medicine was the frontier as the ultimate applied science. And so the chance to work during my PhD studies with Dr. Molly Shoykett was a tremendous opportunity. It's been very educational, very inspirational for the work that I'm currently doing. And Dr. Shoykett does amazing work in bioengineering and tissue engineering approaches to eye disease, but also spinal cord injury and in the brain. So she's considered a world leader in this area, and it's been terrific to continue to collaborate with her even after my PhD on many, many projects we're doing in the eye.
Yeah, she's certainly an inspiration to many people around the world, especially to women who are in the field of STEM, science, technology, engineering, mathematics, because, as a fellow female in the sciences, it's great to have incredible role models like Dr. Shoykett. And so if you haven't had a chance, there's a wonderful episode on Quirks and Quarks about this Killam Prize, and so I encourage all of you to go online and listen to that to learn a little bit more about this bioengineering approach and how important it is to really think about, how are you going to make these stem cell therapies really work in people? So it's that engineering perspective, which I think is a really valuable thing that you bring as well. I see there's lots of new viewers online. This is fantastic. Great. And so because I have a lot of new viewers, I'm just going to reintroduce myself. My name is Dr. Mary Sunderland. I'm the Director of Research at the Foundation Fighting Blindness. And in case you missed it, I'm joined by Dr. Brian Ballios today, who's a clinician scientist researcher with a focus on stem cell therapy. So let's get down to business. If this is your first time joining us, welcome. This is our May e-news. We have these sessions on a monthly basis, and they're really designed to go in complement with our monthly e-news that goes out the first Tuesday of every month. So if you haven't already signed up, we'll have instructions in the comments about how to sign up for e-news, because what we'll be doing today is talking about stories that were featured in the e-news. So it's really sort of, you can do your homework and read the stories in advance, and then you can ask us all the questions about, what these stories might mean to you. And welcome back to our monthly participants. I'm always thrilled. There's a few of you I know who have been with us from the very beginning, and it's really cool because I feel like I'm getting to know these people.
Yeah, that's really great.
And I hope, we haven't announced it yet, but we'll be announcing it soon. I know some of you are joining us from Montreal, and we'll be out in Montreal in October for a live education event, and I'm really hoping I'll get to meet many of you in person later in 2017. So today, as I mentioned, Dr. Ballios and I will be talking about two stories that were in our May e-news, and then we'll also be sharing highlights from the ARVO conference that we were both at. So ARVO stands for the Association for Research in Vision and Ophthalmology. Yeah. There's so many acronyms, it's really hard to keep things straight.
Ophthalmology, yeah. So many acronyms.
Excuse me. So we'll start with the story about Dr. Ballios, because I think that's a great way for you to get to know him a little bit better, learn about his research and some of the expertise that he's going to bring to our session today. Next, we're going to talk about the ARVO Conference, because this is actually the first time that we've had a chance to debrief. Dr. Ballios just got back yesterday. I got back Wednesday night. It was a whirlwind conference, so much going on, and I'm eager to hear.
Busy.
Very busy.
Yeah.
Also,
Very
Dr.
exciting.
Ballios sang karaoke.
But there's no video evidence of that.
There's no, yeah.
It's not on Facebook Live.
And then finally, we'll finish off by answering some of the questions that came in about the CRISPR story that was in our e-news. And so we're thrilled. We had so many questions coming in advance. So we've worked hard to try and kind of put them together in a way that I hope will answer many of the questions that came in. But we're going to protect some time at the end of each story to answer additional questions, because we're really so happy to have everybody joining us on the live feed, and we want to be able to answer your questions as well. But Dr. Ballios does have to go back to the clinic a little bit later, so we might have to cut the session to make sure that he can see his patients on time. So let's jump right into the story about you, Dr. Ballios, which really is an announcement of this Clinician Scientist Emerging Leader Award. And as I mentioned earlier, we really worked hard at the Foundation Fighting Blindness to design this new award to make sure that we are supporting individuals in Canada who are really going to be key in helping us to reach our mission. And our mission, it's simple but hard, right? Developing new treatments and cures for blinding eye disease. We're the Foundation Fighting Blindness. Those treatments can't come fast enough. And Dr. Ballios put together a really strong application to show his plans and how he is sort of thinking about helping us to reach that mission of developing new treatments with the work that he's doing in stem cell biology. So a lot of you sent in questions to learn more about Dr. Ballios' work. So the first question we'll address is one that came in from Sandro. I can't see if Sandro's online now, but I hope he is. Oh, great. I'm glad you're here, Sandro.
Good.
So we're going to start with one part of your question, and we'll tie in another part later. So Sandro asked, what are the main problems that you are finding in your effort to translate your research on stem cells in the laboratory into some kind of a treatment or cure for people who are living with blinding eye diseases?
Yeah, I think that's a terrific question, Sandro, and I really appreciate it coming in. I think it's part of the questions really speaks to why I originally became interested in stem cell research for vision research, and why I thought I could use my engineering background to try to enhance cell delivery. I think one of the major problems that even was present before I started my studies in the eye was one of scale up. This is really an engineering problem at heart. I mean, we had many different stem cells that showed potential for therapy in the eye, But a large problem with getting effective therapies was getting good cell survival after we transplanted those cells into our animal models of vision loss. And so I started off my studies trying to approach that problem head on in a sort of a new and different way. And our first sort of major discovery was that we could use injectable gel materials that could support the survival of those cells after we transplanted them and improve that survival tenfold over what we'd been seen previously of just putting those cells injected in a salt solution. And so I think addressing the post-transplantation bottleneck, after you put cells in where you want them to go into the retina, getting them to survive long enough and integrate, that scale up, getting enough cells there to make a real functional difference for patients, I think that's one of the major challenges that we're still trying to address in our research.
I know, so that problem of scale up, I'm really glad that you describe it in that way, because that's true for people who are working on therapies that involve the eye, but also true for any kind of stem cell transplantation therapies. Going from the cells that you'd be working on with a small animal model, like think about the size of eyes that a mouse would have, quite small, and then you think about how many more cells you would need for a human. Do you have a sense of how many cells you need in the animal model versus how many you need in the human?
I think that benchmark has been evolving over the last 10 years. We used to think that only several tens of thousands, hundreds of thousands of cells would be enough, but I think we're finding that you're going to need several million cells integrated into the eye to get the sort of functional, usable vision back that we need. And so it's a moving benchmark, and part of that is also the other challenge, the second challenge of what we find in our work is one of understanding the real underlying biology of the disease process. I think through our work, as we figure out better ways to get stem cells into the eye and to survive and integrate, that process of discovery and understanding leads new insight into the actual mechanism of the disease. And so it's a bit of a moving target still, because we start learning more about the sorts of cells we need and the type of connections we want from our stem cells in the eye. And that tends to extend our time horizon as we continue to go back to the lab and say, okay, well, we thought we only needed, say, pure cultures of rods, in to replace certain rod diseases, but we realized the rods alone weren't enough. We need them to be with cones or with the pigmented cells. So, and we found out those were very important cell types in the disease process that we didn't understand 5, 10 years ago. So this sort of iterative process where we go forward, we make advances in the preclinical work, and then we learn more about the disease we're interested in. We have to go back and revise our models, our animal models, our understanding, and reapproach that. That's something that's a huge challenge for someone working in the field.
I think, so first I do want to mention, we're actually really lucky today to have some other special guests with us who are kind of behind the camera. And these are our friends from CCRM, who are actually specialists in figuring out those problems of scale up. So this isn't a problem that just Dr. Ballios is working on. We have some amazing expertise in Canada who are really working on that problem as well. And they've got it kind of figured out for the heart. So we want to make sure that the eye is next. Right, Dr. Ballios?
It's about translating approaches. I think what are the common principles that can be used to scale up these therapies between different cell types? And nerve tissue, a photoreceptor is a nerve cell. It's very different than a muscle cell, like a heart cell, a cardiomyocyte. So perhaps there are common principles that we can use that span across different cell types and how to get lots and lots of cells for cell therapy.
And something else that I just want to build on what Dr. Ballios said is that a lot of people, when they think about research, people think about just a straight line forward, and that everything you learn is kind of taking you forward. But science is really much more iterative. It's really this circular path, whereas Dr. Ballios is describing, you learn something and it actually makes you realize that an answer you thought you had maybe wasn't the right answer.
Not quite.
And so here at the Foundation Fighting Blindness, we always want to, we want to make sure that emerging treatments are first and foremost safe, but it's really finding that balance where, how much do you need to know before you're ready to try it out, right? And I think that not everybody agrees on that answer. We're really hoping are ready to be actively thinking about those regulatory questions, because it's a lot to put on the scientists, because they're already doing this whole clinical thing.
Yeah.
Plus they're in the lab trying to make these therapies work, and then to also charge them with trying to figure out how to do a million different forms and paperwork for different regulatory agencies. It's a really tall order. So again, that's something our friends at CCRM are helping us out with.
I think we're very blessed.
So it's great. We don't want to have one person do everything, because that's not really efficient.
No, it's great to have good partnerships. Yeah. It's great to have good partnerships, and I think we're really blessed in the country to have the sort of the people here who are interested in seeing this, and they have the expertise to help move this from bench to clinical practice.
Absolutely. Yeah. So I have a question that's just come in from D.S. McLaughlin, who's asking if in your work you end up manipulating he's describing this as the hormonal milieu for transplanted cells. So perhaps he means, do you have to introduce new growth factors or things? You know, you mentioned the biogels that you're using.
I mean, certainly during the development of the cell and the cell therapy in the dish, you have to add different sorts of factors. Some of them are hormonal, some of them are growth factors, and a lot of this is to help purify and get a pure population of cells that you want to transplant. A lot of our work has been in transplanting rod photoreceptors, but also the precursor cells, the ones that are committed to making rod photoreceptors before they've matured into rods, and now we're looking at cones as well. But I think so you certainly need to manipulate their environment in the dish, but I think the unappreciated fact is that you also need to create a receptive bed for them to integrate into. And so the advantage of using a bioengineered approach is not only can you keep those cells distributed and add survival factors that you need when you do the transplantation, but that also you could potentially use that gel or that vehicle, whether it be a gel or otherwise, as a scaffold, as a way to deliver factors to manipulate the host environment. And so getting eventually towards a combined approach of something that's both a cell therapy but also a drug therapy. Yes. I think that's the dream of a true bioengineered approach to cell transplantation.
Absolutely. And so, around the Foundation Fighting Blindness, we've been talking this year a lot about the race to restore sight. There's lots of different approaches that are being actively researched: stem cell therapy, drug therapy, artificial vision, gene therapies. And when we think about who's really going to win, when we talk to the experts like Dr. Ballios, it does seem like those combinatorial approaches that draw on the wins from all the different fields. And so if the problem is cells dying after you put them in the eye, what if you put in a drug to help them survive? So it makes logical sense. Brian, I could talk to you about research all day, but we're going to have to keep moving on to our next question.
I know we've got an agenda.
So the next question I want to address is from one of our friends named Josette, and she's really excited about the work that you're doing, and she wants to know how she can get on a list to participate in your clinical trial. So let me try to answer that question first. So Josette, so many of our viewers have the same, versions of the same question as you. And so to start off, I have to clarify that Dr. Ballios' research is not currently in a clinical trial. So right now, he's still working in the laboratory. So we call that preclinical research. It means that he hasn't figured out all of the answers that he needs to test something in humans. And so I know many of you are eager and you'd come line up at the door today if we said we were ready, but we have to be so careful because this is all brand new, right? Like, we are pioneering, this is a new path forward, and if you rush ahead and you bring something forward that is dangerous, it can set the field back like a decade.
It can be extremely damaging to the progress that we're making. And there's reports out there of different stem cell trials, even as recently as in the last year, that are with therapies that maybe don't have the same level of rigorous evidence necessary to launch into a full-scale clinical trial, and the unfortunate and devastating outcomes from those also negatively impact the field advancing as a whole. So it can be rushing headlong can be very very dangerous.
Yeah, and this is a comment that actually came up in a different context, but I'll bring it up now just because it fits. And one of our viewers kind of wanted us to comment on these, I think they get referred to as adipose stem cells, fat stem cells, and this is the trial that Dr. Ballios was referring to. Just last month, there was a publication in quite a prestigious journal, the New England Journal of Medicine, kind of exposing this trial happening in Florida that really shouldn't be happening at all because it's not ready.
Yeah.
And so, what are your thoughts on that?
I mean, my take is that with patients signing up for trials where the evidence is just not there yet. I mean, I don't think we have the strongest evidence that the adipose-derived stem cells can do what was being purported they were able to do, which is turn into retinal cells. Now, we may find out that those adipose cells are useful in terms of producing different drugs down the line, or different factors that can help in different disease contexts. But I think that's it just highlights the danger of rushing headlong into a therapy and just starting to inject cells into an eye where we're really not sure what they're going to do. And in those patients, unfortunately, had very poor outcomes in those presentations. It's very interesting that in the same edition of that journal, Dr. Masayo Takahashi from Japan was highlighting some of the success that her group has enjoyed with using patient-derived stem cells for macular degeneration, and some early encouraging results of their first patient. And so it was interesting that those two papers were highlighted side by side, and I think it, in many ways, the sensation that caused of seeing the negative outcomes in that first report on the adipose-derived stem cells, in some ways eclipsed the really exciting results that were going on, and that's a bit unfortunate.
It is unfortunate.
And I think it casts a bit of a negative light on potentially some very promising therapies. I think people have to remember that not all stem cells are created equal. There's not one such thing as a single stem cell. They have many, many sources, and they can be used to do many, many different things. So,
yes, there's your take-home message. Not all stem cells are created equal, and not all stem cell trials are created equal. So I was like giddy at ARVO because I was sitting. Dr. Masayo Takahashi was sitting right behind me.
Starstruck.
I was totally starstruck. And she gave such a beautiful presentation. She's seen incredible results with her trial, which is focused on treating wet age-related macular degeneration. This is a disease that's typically treated with repeated injections of anti-VEGF drug. And since she's done her stem cell transplant, this patient hasn't needed any drugs. And it's incredible. Granted, they are not over-sensationalizing their results because they've only done it on one person. And so in the world of science, before you can make big conclusions, you need a bigger trial than one person. But unfortunately, this other paper reported that 3 women went blind who actually had pretty decent sight before going in. So it's just pay attention, look at the fine print, and if it seems too good to be true, Probably is. Yeah. So I also wanted to then respond to Josette's question about, well, let's look into the future, and let's hope that Dr. Ballios' work is ready for a trial sometime in the near future. How would you make sure that you're kind of on the list for a clinical trial? So first of all, it depends on where you live. Josette, I'm not sure if you're joining us now or where you live. So if you live here in Canada, we have the Foundation Fighting Blindness Patient Registry. And so we'll make sure that we have instructions about how to sign up for the registry in the comments section of this video. This is something that we're often talking about because we're really proud of the Foundation Fighting Blindness Registry. It's a very valuable database that's full of anonymized data. It means that when you go in there, researchers can ask for permission to look at information about your vision health, but they don't know who you are, so you can retain some privacy. But it's overseen by leading ophthalmology specialists in inherited retinal dystrophies. So those are diseases like retinitis pigmentosa, juvenile retinoschisis, Stargardts Disease. There's a long list of them. And right now we have about 1,200 patients in the registry, and it's headed by Dr. Elise On at Sick Kids. We also have a site on the West Coast headed by Dr. Kevin Gregory Evans, a site in Edmonton, Alberta headed by Dr. Ian McDonald, and our Atlantic Canada site headed by Dr. Joanne Robitaille. So please reach out to us, and we're always happy to give you more information about how you can make sure that you're enrolled on the registry. So, and you just need to let your doctor know, if you live somewhere else in the world, make sure that you let your doctor know that you're interested in being involved with trials, and ask your doctor if he or she is involved in trials. If they're not, ask them to refer you to someone who would be involved. Does that seem like something?
I think that's important. I think that the first place patient should always start speaking to their ophthalmologist. And communication's a two-way street. And there's a lot that ophthalmologists can learn from their patients about what's going on in the field, especially very informed patients who know a lot about their disease and maybe what things are out there. So I like your last point about saying, asking and saying, would it be appropriate for me to get a referral to somebody who might be involved in the patient registry? I think a registry is a terrific way to collect patients with different types of diseases that may be amenable to a future therapy. And I certainly see part of my role is helping to educate other clinicians too, that this registry does exist, and that there are places that patient can go to get connected into clinical trials. And it doesn't need to be your ophthalmologist who's engaged in that clinical trial, but at least someone who can link you in to being to the registry, so that you could be on the list for future therapies.
And we're really committed here at the Foundation Fighting Blindness to try and bring more clinical trials that will be accessible to Canadian patients. And I know that's something that our partners at CCRM are really enthusiastic about. We work with Clinical Trials Ontario to find ways to make sure that Canada is an attractive place for clinical trials. And the work that you can do is, as a patient, put your hand up and show that you're willing. The really engaged people like our friends here that are joining us, I know that many of them would be happy and eager to join a trial. And you may find it hard to believe that one of the main deterrents, one of the main reasons why trials don't come, is because the patients aren't there. So, excuse me. And so our third question, and this is a variation on a question that many of you asked, $1 million question: when will it be ready?
I mean, I think that's our hope is always sooner rather than later. I think the danger of putting that date on things is that we, as I spoke to before, a lot of the science is a moving target, and as we're developing new therapies, we're understanding more about the disease that we're treating, and so my hope is that we see, as my practice matures, that I can be the physician who's applying some of these therapies to my patients in the future and saying, I was there when we were developing this as a young scientist. But I'm hopeful that in the next 15 years we can see some very evidence-based approaches that are already on the market. I mean, we already have stem cell therapies. Oh, Mary, take a second.
Sorry.
I mean, we already have.
Guys.
Oh, yeah. I mean, we already have.
I didn't think I was going to have a coughing fit, but I couldn't help myself. Excuse me. Thank you.
We already have stem cell therapies that are in phase 1, phase 2A dose escalation trials, and they'll need to go into a phase 3 and phase 4 trials before they really, or phase 3 trials before they're really safe to come to market. And that process does take some time. But there's already several trials in North America and across the world, actually in the UK as well as in Japan. And so we're very hopeful that can come in the next 10, 15 years.
Sorry for interrupting your very well thought out answer. Excuse me. Sometimes I can't control my coughing fits.
That's okay.
So, what I wanted to clarify, some of our viewers might have heard you say 15 years and been like, oh, come on, 15 years. Can't you do it faster than that?
Well, I think, for those trials that are already ongoing, I mean, those ones we can expect to come out sooner, probably within the next 10 years. But I think for some of the newest trials, the ones that aren't using the pigmented cells, the ones that are using neurons, I think it's probably more realistic to think, 10 years or so. I mean, these are typical timelines for drug discovery and drug development. And so I think that while some of the earliest trials will probably come out in the next 10 years, we're going to see an explosion after that. Once that regulatory landscape is cemented, once we know how to get a good cell therapy from a stem cell through to a cell that's usable and into the eye, I think that's a reasonable target.
Well, I think this is actually a really nice segue into our conversation about ARVO, the ARVO Conference, because we were both really excited about many of the papers and posters. Did you know that scientists like to make posters for each other? That's how they like to communicate.
Our science, yeah.
Kind of an interesting form of communication.
It was a little bizarre.
And like little tiny print. This.
Yeah.
Excuse me. But one of the groups that seems to be sort of furthest along with their photoreceptor transplantation is Dr. Bud Tucker's group at Iowa.
Oh, yeah.
So I was going to let you talk about Dr. Bud Tucker while I go to stage right for a minute and just kind of compose myself so that I don't cough on anybody in this room with me right now.
Take whatever
so
time you
I'm
need.
going to take a moment and you talk about Dr. Tucker and I'm going to come right back.
Sure. I think Mary touched on a really important point with Dr. Tucker's work. Dr. Bud Tucker is doing some very exciting work around 3D engineered retinal implants, and those cells are actually grown on a three-dimensional matrix, which his group is looking to transplant into the retina, and it's essentially an artificial retina that's engineered in the dish that's going to be put into patients, and the idea is that will be very useful in diseases where the outer retina, the part of the retina which senses light, is completely degenerated, so in very late stage disease of many different types, and that that matrix with that full complement of retinal cells will eventually be able to integrate and attach itself into the host, into the network. But I think that I think that you have to tailor your approach for different types of disease. So in disease where the retina is still for the most part intact, where most of the photoreceptors are still present, or perhaps only some of them had degenerated, it may be very useful to have a suspension of cells in a gel, just the cells that you want injected, as opposed to a full retina being transplanted into the eye. Yeah. Oh yeah. So we do have another question. Yeah. Oh sure. Okay. So there's some questions on the CRISPR topic, which I think is very relevant to what we've been doing at ARVO. And there's the second question. Sure. Yeah. Oh, okay. Here's a question from Renata. Okay, coming back from the ARVO 2017 conference, what is your immediate impression on the challenges associated with the translation of new therapies into cures and the feeling of patients on the involvement in clinical trials? Well, I think that's a really great question, Renata. I think, the challenges, we've highlighted already some of the challenges associated with translating new therapies into cures. I think part of that involves understanding the disease process probably better than we already do, but also finding common approaches that will work for multiple disease types. So as we know, retinal disease it doesn't just fall into one particular diagnosis, one particular flavor, and we need to find common approaches that are going to work for multiple different pathways of disease. And so what we have, what's very exciting going on at ARVO this year was the work we saw around using a toolbox, the CRISPR toolbox, to edit genes that could potentially be useful in transplanting these cells back to restore their function after they've been grown up in the dish. And so developing a common toolbox, I think, is one way to address the challenge of having many, many different types of disease and trying to use stem cell therapy to address all of the different kinds of disease.
Mm-hmm. I'm so glad Dr. Ballios is here today. For many reasons.
You're feeling better.
I'm feeling better.
Good.
So I also thanks for talking about Dr. Tucker's work. He spoke right before Dr. Masayo Takahashi, and it was such a great session. Did you speak about the scaffolds that he's doing?
I did, and we talked a little bit about how those scaffolds may be very useful in patients where very late disease, where most of the retina has degenerated, and you're looking to replace a lot of cells, or even an organized structure of cells in the retina. But that in earlier disease, where you're only missing a few different cell types, it may also be useful to just inject those specific cells that you're looking for, either supported on a matrix or in an implantable gel, just to target those early cells. But his approach is definitely very promising, I think, for late-stage disease and many different types of etiology.
And do you remember how many genes that he indicated that he'd corrected? Was it 20 or 30?
I think it's something like 25 different genes that he had looked at correcting with the CRISPR technology. The idea being that you could take the patient's own cells out with the IPS, induced pluripotent stem cell technology, make retinal cells that are unique to the patient, but correct the gene defect that causes the disease, and then transplant that back in. And he's tried that by isolating cells from patients with many different types of retinal disease, and showing that he can correct the gene deficit. Now that's a very elegant approach when you have one single gene that you know is the cause. But we're discovering more and more is that for conditions like retinitis pigmentosa, like even age-related macular degeneration, that there are many, many different genes involved in creating that final disease type. And so the challenge then becomes, which are the important genes to correct? And we know that we can use CRISPR to correct multiple gene problems, but have we got all of the right ones? And what's going to happen when we've corrected all of them? Will we really be able to restore the normal function of that cell that we're going to transplant?
But speaking before our session, Dr. Ballios and I both agreed that there was a lot of excitement around CRISPR and the potential for CRISPR to really, really accelerate the entire process. I mean, one of the things that it does is it allows scientists to develop models of very specific genotypes that previously would have taken months and even years, and now they can do it in a matter of weeks. And so I wanted to make sure I had a chance to talk about Dr. Orson Moritz, who's a Foundation Fighting Blindness funded scientist. And I mentioned his work on one of the videos that I did because it was such a great paper, a really beautiful poster with really nice images. And it is led by one of his PhD students who also works with Ruan Ben-Schmidt. And so many of you might have gotten to know Ruan. She spoke at one of our sessions in Vancouver. And so this is work that he's doing with an animal model called the Xenopus frog. And he's able to generate brand new specific mutants in like a few weeks. It's amazing. And so we shared this work that Ruan had done, which really highlighted, valproic acid. It's been talked about, does valproic acid work to treat retinitis pigmentosa? It's kind of been out there for a long time. And what Ruan was able to find by looking at her Xenopus models, that in some genetic forms of RP, valproic acid slows down the disease progression. In other forms of RP, speeds up disease progression. So the take-home message is, RP is a really diverse diagnosis. It's a big umbrella term, and you need to advocate. You need to be a self-advocate and keep going back to your doctor and say, genetic testing is important. We'll make sure we have a link in our comments that you can get our sort of guide to genetic testing. You can bring it to, you don't even need to go to your ophthalmologist. You can go to your optometrist for a referral about how to get your genetic testing done. And I'm thrilled to report that Dr. Kevin Gregory Evans was speaking at to someone in the BC government this morning to lobby to have genetic testing paid for in BC. So this is an issue. There's a lot of inequities across Canada, and we're doing all that we can to make sure that patients get the care that they need. And we really believe strongly that genetic testing should be standard of care for people that have a retinal dystrophy diagnosis. So what the finding of Dr. Moritz's most recent poster was, with these new models he was able to develop, it's the same kind of finding, but for vitamin A. In some certain subsets of RP, vitamin A seems to slow down the disease progression. In other forms, speeds it up. So, if you don't know what your genetic diagnosis is, you should be careful, right?
You're going in blind to a therapy that may be helpful or may even be harmful. So I think that's I think you very well highlighted what the real exciting thing about CRISPR is that we've known for a long time how to edit genes and how to make these models. But what CRISPR does is gives you a toolbox that will allow you to do this just that much faster. You can have your model up and running in just a few weeks with very basic reagents in the laboratory, and you can get onto your testing right away. So I think that's probably the most exciting thing about CRISPR, and these targeted approaches to stem cell therapy, I think, are going to be very relevant as we develop new therapies.
I see some questions coming in about CRISPR. Well, before we get into these specific questions, let's actually shift into our final story, which is about CRISPR.
Yeah.
This is a story that was on our website. I didn't write down the full title of it, but we'll make sure it's in the link because you can do your homework and go read the full story. This was a really exciting sort of scientific discovery that we wrote about out of a group in California who used CRISPR to edit out genes that were really important in the development of the eye. So 2 genes called NRL and NR2E3. And so these are not genes that are necessarily implicated in RP or Stargardts. These are genes that are important for retinal development. And what they found is that if they knock out these 2 genes, they can turn rod cells into cone cells. So this was really an exciting, what we sort of call like proof of principle discovery. Because we talk about one of the big challenges for this, creating treatments that could work for many different forms of diseases is that, these diseases are all kind of different, and do you need a specific treatment for each genetic form of the disease? So we were excited by this because it could potentially offer therapeutic benefit to many different forms of the disease. So I was wondering, let's jump to some of the questions. We have lots of questions about it. So many of our Facebook followers wanted to know, how they can access the treatment and what they need for genetic testing. I think I kind of addressed that previously. Yeah. So, chime in with the comments if you need more specifics around this. Many people, again, are curious to know when this treatment will be available for them. And so I have to say, it's not a treatment yet. And the term I use to describe is proof of principle. So maybe, Dr. Ballios, could you elaborate this is a term that's very common. It's like scientific term, proof of principle.
Yeah.
Could you elaborate?
I think even before you get to, I spoke much earlier in our talk about issues of scale up and about developing a therapy to be useful clinically. A proof of principle is, you have an idea about how a certain strategy in regenerative medicine might work, and you use whatever your best model of disease is to try to demonstrate that this approach reverses that process of disease, at least at a small scale or in principle. And usually it involves applying either a new approach or a new tool, like some of the new gene therapy editing approaches. And you're showing it, and it's a very small scale study. And it's usually looking at maybe only 1 or 2 very specific endpoints. Like, can we turn that cell, that rod, into that cone? And does it seem to function like a cone with maybe 1 or 2 tests of cone function? But it's not doing the sort of more elaborate testing you need to show, is it restoring some sort of usable visual sight? It's about testing at the very small scale. And so it's where you take that concept, which you've shown to have a positive proof of principle, that you then take forward to say, well, now, how much of the retina can we treat? Is this going to work for every type of variant of this disease? Is it going to cover enough space? And you start to get into more technical ideas around how you'd actually translate that into a usable therapy. I think a proof of principle is very exciting. I think it demonstrates really the resurgence we've seen in the last year or 2 around gene therapy that's come up with the new CRISPR technology. Gene therapy's been around for a long time, longer than cell therapy and stem cell therapy in many ways. But with the new techniques for gene therapy, we're seeing a renewed interest in gene therapy, and we're seeing how it can integrate into cell-based therapies. I like how you mentioned at the beginning that this particular paper borrowed from development. I think a lot of what we understand about stem cell therapy, a lot of what we understand about the mechanisms of disease are informed a lot by what we understand about how the retina normally develops. And so addressing these genes which are not implicated in disease but are rather implicated in specifying a rod instead of a cone photoreceptor, manipulating those genes, is a very big conceptual leap into how we think about we might address multiple diseases with a single therapy. Yeah.
So it really, these proof of principle studies kind of open the door to an entirely new approach. And some of you might say, but what about that other approach that you haven't even, can't you just stay focused and just take that across the finish line before you keep opening these doors to other new potential approaches?
You have patients with many different diseases. They all want therapies for their disease, and yes, you could keep running down different avenues, but if you're able to develop a more generalized approach, to think of it like the anti-VEGF therapies like Lucentis that's already been developed, not only useful in wet age-related macular degeneration, but now useful in diabetic retinopathy.
That's true, actually.
Right now, also useful in myopic degeneration. So it's a single type of therapy that addresses a very fundamental thing about how that disease works.
Yeah.
And I think we understand that about how wet age-related macular degeneration or how new blood vessel growth works in the eye. If we can understand that better about genetic disease, about retinitis pigmentosa and common pathways, we can understand better. And then we may be able to find something that can supersede the problems that we found with vitamin A, for example. We talked about vitamin A sometimes helpful, maybe sometimes harmful. But if we could find a more generalized approach, then that's going to, we may be able to develop a therapeutic that's as helpful as the anti-VEGFs have been for age-related macular degeneration.
And even you mentioned the one form of anti-VEGF, Lucentis, which was sort of the first one formulated for the eye. Since then, we've had Eylea, Avastin, and so you can see that this kind of approach, 10 years ago, there was nothing for people with wet AMD. Now there's like many different drugs, and so it's stories like that fuel our hope, show the importance of science, the incredible impact that you can have on many different diseases.
Yeah.
So it's going to happen for retinal dystrophies, and I know that it just feels like it can't happen soon enough, but it's that message of rushing ahead isn't necessarily the good way to go.
It's always the best. You may not, and you may not catch all the patients you want to catch in that therapy. You might be developing a therapy for a very specific variant of the disease, but you're going to miss treating all of these patients who have other types because you've created something so very, very specific. Not that it's not helpful, but that you have to think about people with many different types, and remember that the disease is incredibly varied.
But what I should say too, and this is a message, didn't even mention that Dr. Ballios is such a good sport. Last night he was at one of our really fun fundraising events.
Yes.
Comic Vision Last Call.
Great.
This is fantastic. How much money did we raise last night? Do you know? Lots of money. But you know what? No matter how much money we raise, it can be frustrating because the closer that we get to sort of these clinical studies, the more expensive research becomes.
Yes.
And we have invested so much in this early stage research. We have these incredible proof of principle results. We have people like Dr. Ballios, people like at CCRM working on scale up, but we always need more money, and so we need to raise awareness to the government, to the Canadian government, to wherever you may live, that we need more support to take these things across the finish line. So people, if you ask, one thing all scientists and everybody, all stakeholders can agree on is that we need the investment to take it across. Yeah. And the other thing, from a scientific perspective, that really excites me about the eye, and just to feel the buzz in the air at ARVO, like it's happening. These clinical trials are happening. Yeah. And it's not just an idea anymore. It's not just science fiction. Did you go to that session on artificial vision?
Yes. Yeah, that's a very neat session.
Where now, the Argus device is being used in people with AMD, and it combines, restores part of their sight, but it's amazing. All of this stuff is happening.
I think people forget that it's not just one particular, not just regenerative medicine. There's the retinal prostheses or the interaction of technology with vision restoration is already going into the clinic and into clinical trials, and there's so many different modalities that are being developed in ophthalmology. That's why I think it's one of the most rapidly expanding surgical specialties, ophthalmology, for treating eye disease compared to many other types of of disease. And one of the things that got me very interested in doing it as a career was that I think the advances we see in science, not just stem cell biology, but what we know about optics and lasers and implants and technology interfacing with ophthalmology, and how fast we see that move to the clinic is faster than we see in almost any other specialty.
Yeah. And I mean, this conference that we were just at, it had more than, originally I thought 10,000, but there were more than 11,000 scientists, and they all love vision research. They love working on the eye because of this incredible imaging that you can do. You can see if stuff is working or not working. You can do all of this like stuff that you just can't do if you're looking at treatments that are way down deep inside of your body, right? Like the eye's right there. And
the retina is the only tissue it's brain tissue. That's the only part of the brain that you can see from outside the body.
Yeah, so it makes it like very attractive to like the brightest minds in the world who like the people that want to see results, they get attracted to the eye because the results are coming. But, you'll see results. Almost like I planned that. So I got sidetracked. So you were going to comment about. Oh my goodness, Brian! I'm going to have to let you go soon.
Oh, it's okay.
Because
we can do
your
a few more
patients
questions.
need to see you. So there's comment about whether this sort of CRISPR approach might be able to work with Stargardts disease. So we kind of have this message about, you need to learn about the biology of your own disease, but if you want to comment further
Well, I think it speaks to what we were talking about before in vitamin A processing. If we understand what the disease, what the specific genes are and how they play, it's a multi-genetic process. There's no one single gene that can be implicated. And so I think that in some cases it's a single genetic defect that we know of. But once we understand more about the disease, we can figure out how to use CRISPR to perhaps do the gene editing that will make other therapies like vitamin A supplementation, other things work even better for that particular disease. Once we know about how those biologic pathways work, then the CRISPR gives us that toolbox to do the editing.
Another question about CRISPR is, do you think it will be able to regenerate cells that are no longer working? Or do you think, do you have a comment on that?
Yeah, I think that's really important.
That question comes from Debbie.
Oh, yeah. Okay. Well,
Debbie's online with us.
Thank you, Debbie. I appreciate that question. I think that's a very, very important question when you think about how to use gene therapy and regenerative medicine. I think we could all agree that the ultimate dream of stem cell or regenerative medicine is that getting the body's own tissues to regenerate itself, not needing to do different sorts of interventions. And certainly in our own lab, we're looking at ways to reactivate stem cells that may be quiescent or quiet or dormant in the native tissue. Now, using CRISPR to reactivate things. Now, a lot of what's been going on is using CRISPR to fix very specific gene defects in the diseases. But at a more general level, getting CRISPR to wake up cells that no longer replicate, to get them to replicate again and heal the retina from the inside. Well, now that's a very exciting idea. I think the challenge and the red flag on that particular approach is making sure that we understand what exactly we're reactivating so that we don't get into a situation where we've created cells now that just keep growing and growing and never stop, and then you get into a situation where it's essentially similar to a tumor in the eye. And so it's a very exciting idea to wake up cells that have already been asleep, or to get those cells to regenerate and heal the retina. But we also have to have checks and balances. We also have to understand which genes we need to edit to get that process to be a self-limited process. So I think it's exciting and definitely one way to unlock that potential to get the body and the retina and the eye to heal itself from the inside. Because so much of the CRISPR work right now has been trying to edit the stem cells in the dish and get them transplanted. I think that this is a really exciting way forward, but you have to be aware of the potential pitfalls.
And again, something that we can learn from the wisdom of studies and development, where just because like humans can't regenerate their eyes, there's lots of animals that can. So we can learn a lot by studying fish that can regenerate their eyes.
The zebrafish model, the xenopus, which you mentioned before.
So we're coming to the end here, Dr. Ballios. Do you think we have time for one more question? I think one of the questions is just, I see some questions coming in. Is there something you wanted me to address? We like to engage people who are online because we really appreciate you being here with us. Well, Carolina just wanted to know if this kind of CRISPR procedure would work for both autosomal dominant patterns of inheritance or just recessive. Like, if you could comment on.
Yeah, I mean, I think the CRISPR is great because it again, it's a general approach to fixing gene defects, and so you could use it to fix many different genes regardless of their pattern of inheritance. It's important to note that the strategies that are being developed to act on genes locally in the retina. There's no right now research, at least eye-related, to correct the gene defect in an inheritable fashion so that you no longer pass it on to the next generation. That gets into issues around germline editing and reproductive biology, which of course CRISPR has entered that field, and people are starting to ask about how you can correct those gene defects. What this therapy that's being reported on is focused on correcting the gene defect in the individual, locally, in the retina, as opposed to changing its inheritability or removing its inheritability whatsoever.
Which sort of raises more ethical questions.
It certainly does. I mean, it's a field that I don't address directly through my research, but as a physician, I mean, patients come to you and they ask you around genetic counseling, what's the risk that my offspring, male or female, are going to inherit this particular condition that I have? I mean, I think that then they want to know about how the CRISPR gene therapy might be applied to that particular situation. I think that that's going to require a lot of delicate thought of how we go into applying CRISPR in reproductive health.
And experts are thinking about it. You know, it's but not everybody needs to think about everything at the same time.
Let's start with the retina for now.
You've got a lot to think about. So, you know what, Dr. Ballios? This is our longest Facebook Live session ever. We
felt like the time flew.
And you know what? It's our most watched.
Oh, great.
And have we hit 3,000 yet? Oh my gosh, can somebody like us? Because we're about to hit 3,000 likes, and that would be amazing. You know, if you invite a friend, and then we hit 3,000, we're going to have a real party.
That'd be amazing. Yeah. Wow, terrific.
We're there!
Hey, nice. Oh, amazing. I won't leave you
That's
hanging.
fantastic.
That's great.
What a beautiful way to end this really lovely session
forum.
that we've had.
Great.
So thank you to everybody for tuning in. Thank you, Dr. Ballios, for joining us. It was a fantastic session. I learned so much. I was taking notes. I know we couldn't get to every single question, but we'll follow up with everybody. And if I can't find answers, I'm sure that Dr. Ballios will help us figure out the details. And so if you haven't already signed up, please sign up for our FFB e-news. This is the way that you can get the stories in advance. The link up above, very easy to do. And that way, you'll be all ready for our next e-news and Facebook Live session in June, when it's going to be the summertime. Thank goodness. Can you believe it? So it's been amazing talking about research with you today.
I appreciate it. Thank you very much.
And it was, really energizing to come off of ARVO, go raise some money at Comic Vision for research, and then talk about the possibilities.
Yeah.
And congratulations to Dr. Ballios, the inaugural clinician scientist emerging leader.
Oh, thank you. That's kind.
Congratulations.
Thank you.
Goodbye, everybody.
Bye-bye.
We'll see you next time.